So next is esophageal cancer V11, and before discussing the clinical scenario, we will discuss basic science. What is Seward classification? All the junctional tumors are classified by Seward classification. Type 1 is the adenocarcinoma of the distal esophagus, male filled gastroesophageal junction from above, and it is considered as esophageal tumor. And Seward type 2 or the carcinoma of the cardia arising immediately at the gastroesophageal junction, often referred to as the junctional carcinoma. And grade type 3 Seward is the subcardial gastric carcinoma that infiltrates the gastroesophageal junction and distal esophagus from the below. 62-year-old man with a long-standing history of gastroesophageal reflux presents with symptoms of progressive dysphagia. How would you manage him? I strongly suspect he has esophageal cancer. I would take a history regarding the dysphagia, like slow or gradual onset dysphagia to solids or liquid, and associated weight loss, smoking history, respiratory symptom, infection, involvement of respiratory tract with the change in the sounds. I would examine the patient looking for signs of more advanced disease like supraclavicular cervical lymphadenopathy, hepatomegaly, abdominal nodal or mental mets. Part of clinical assessment would also involve consideration of fitness for surgical, curative treatment and nutritional status. I would arrange an urgent OGD with biopsies, at least 6 biopsies sample from any suspected gastroesophageal pregnancy. The OGD demonstrates a malignant appearing tumor infiltrating the gastroesophageal junction from the above. Biopsies confirm adenocarcinoma. What staging investigation are appropriate for this scan? I would arrange CT scan of the chest, abdomen, and pelvis with IV and oral contrast of water to assess for metastatic disease and the extent of local invasion of more advanced tumors. Provided there is no endovenous mets, I would then arrange PET CT and EUS. PET CT is utilized to assess regional nodal disease and distant mets. EUS is used for more accurate staging of tumor and to assess the regional lymph node involvement, and FNA sample may be obtained. For T1 tumor, EMR is more sensitive method of differentiating mucosal from the submucosal penetration, and then laparoscopy for direct visualization of low volume peritoneal and hepatic mets tends to be preserved for type 2 and type 3 tumors and less for type 1 tumor given the pattern of the disease spread. What are the next steps in this in his management? I would discuss his case in upper GI MDT, informing the patient of all results and the MDT recommendation. In the absence of metastatic disease, if you are medically fit, I would offer him an esophagectomy after neoadjuvant chemotherapy. The aim of neoadjuvant treatment is to reduce the tumor volume and to increase the rate of R0 resections. There are two trials. One is MRCOEO2 trial, which randomized the 802 patient to surgery alone or 2 cycles of cisplatin and 5 operative surgery. The group receiving chemotherapy was shown better disease-free and overall survival at 2 and 5 years. The trial included adenocarcinoma and squamous cell carcinoma patients. The role of preoperative chemotherapy in the management of esophageal cancer is also evolving but not yet fully accepted in the UK. The cross trial compared the chemoradiotherapy followed by surgery with surgery alone or in patients with esophageal and esophageal junctional cancers. Overall survival was significantly better in the chemoradiotherapy group, median of 49.4 months versus 20 months with the acceptable adverse event. The estimated 5-year survival is 47%. The ongoing neo-AGAS trial will assess the sandwich chemotherapy versus the neoadjuvant chemoradiotherapy for esophageal cancer. What surgical approach could you use to resect this tumor? So there are 3 surgical options: 1 stage esophagectomy, 2 stages esophagectomy, and 3 stages. So I would prefer 2 stages called ivermectin or Iverleos. Involve the mobilization of the stomach and the creation of a gastric conduit followed by a right thoracic approach to the esophagus to resect the tumor and a smooth conduit to the proximal esophagus in the chest. 1 stage esophagectomy is via the left thoraco-abdominal approach, provides maximal exposure of the gastroesophageal junction, allowing good opportunity to clear the maximal circumferential paraesophageal tumor. The 3-stage esophagectomy involves a prone thoracic phase or mobilization of the esophagus and tumor, followed by laparoscopic abdominal phase to create the gastric conduit and left neck incision to anastomose the stomach to the cervical esophagus after removing the specimen through an extended abdominal port site. Thank you.